Good morning, good afternoon, and good evening to everyone joining from around the world. On behalf of the WFSA and the Global Health Workforce Program, welcome to our second webinar in this p-PBM series. Today, we'll have Saving Lives When Blood is Scarce, applying perioperative p-PBM in trauma and obstetric hemorrhage. Trauma and PPH are among the world's leading yet preventable cause of death. So today we'll explore how p-PBM principles can be applied to these emergencies, especially in the setting where blood is scarce, unsafe, or unaffordable. My name is Diana Castro Palperio. I'm an anesthesiologist from Portugal. I mainly dedicate myself to cardiac anesthesia, but from the last 8 years, I'm fully committed to patient blood management. And it's my pleasure to be here in this webinar, trying to make everyone understand how perioperative p-PBM principles can reduce mortality in trauma and PPH, identifying non-transfusional practical strategies to manage bleeding emergencies, recognize how rapidly active local workflows and teams for timing bleeding control, and to promote cross-disciplinary collaboration to expand p-PBM beyond tertiary centers into district-level hospitals and health posts. Before we go into our webinar, just some housekeeping. The Q&A questions can be submitting through this Zoom webinar in the Q&A function. There will be translation simultaneously in Amharic, listen in real time, or you have AI live subtitles. Please just choose your preferred language in the settings. The certificates will be issued for you. Just attend the webinar for 60 minutes and don't forget to fulfill the survey after the webinar. Also, the recording will be published in the YouTube soon. So if you just have a good time in this webinar, and if you want to see everything again, that will be available. Today, we'll have 3 distinguished speakers that will share their expertise. We will start with Emilia Guasch, an international recognized expert in obstetric anesthesia and patient blood management. So Dr. Emilia, she's currently working in the Hospital Universitario Jiménez Díaz in Madrid. She's also honorary professor of anesthesia and intensive care, also in Madrid. She's a current member of the ESAIC board. She has held responsibilities in the obstetric committee of ESAIC, and her main research interests include labor analgesia and anesthesia, PPH, and obstetric patient safety. She will talk to us about applying p-PBM in obstetric hemorrhage from prevention to system preparedness. After Dr. Emilia, it will be a pleasure to have Dr. Seema Ranade, a freelance anesthesiologist in Mahat, India, from the other side of the world, where she works alongside her husband, an orthopedic surgeon. Together, they run a 20-bed trauma center that manage a high volume of road traffic accidents and polytrauma. Fully committed to providing quality healthcare in a region with limited resources, Dr. Ranade has become a trusted figure in her community. Her main areas of interest are trauma and obstetrics, where she applies careful planning for blood management and urgent resources to improve outcomes. Her talk will be entitled p-PBM in Trauma, Saving Lives When Every Drop Counts. And the last but not least, we'll have my dear friend, Dr. Angel Calatayud, Head of Division of the Critical Care Areas in General Hospital of Mexico. He is a specialist in medical surgical emergencies and subspecialist in critical care medicine. He's the Head of Division of Critical Care Areas, also in Mexico at Dr. Eduardo Leseaga. He is a level 1 member of the National System of Researchers in Mexico, a scientific advisor for IF-p-PBM, a founding president of SIA p-PBM, a national coordinator for p-PBM in Mexico, and also, we are so proud of Dr. Honoris Causa, a health leader. Dr. Angel will talk us about integrating p-PBM into emergency protocols, tools for action, and audit. So We will start with our first guest, Dr. Emilia, and to start, we'll have her disclosures. And because she was not able to be online at this moment, we'll have a recording of her presentation. Please, Dr. Emilia.
Hello, everyone. Thank you very much for inviting me to speak about patient blood management in obstetrics, focusing on p-PH. We have to remind about maternal mortality rate and maternal mortality rate and workforce map in the world about anesthesiology run parallel. So the anesthesiologists have a lot of things to say and to do to decrease maternal mortality. And why are we so concerned about pregnant women and PBM? Why are they different? Because there is a high prevalence of iron deficiency in pregnant women, because p-PH affects millions of women and it's a leading cause of maternal mortality and morbidity worldwide, and because postpartum anemia affects neonates and families, not only women. There are gender biases in this topic because pregnant women are considered healthy people and women's health is not always so important. And in high-income countries and in low-income countries, we share the same problem with different causes. Anemia is one of the main drivers of transfusion. And anemia is a very important issue as it affects a lot of women and a lot of population across the world. And physiological anemia, we are not so sure that it's so physiological during pregnancy. Efficacy and safety of transfusion may be suboptimal, so it may increase adverse clinical outcomes, including morbidity and mortality. The World Health Organization has raised the awareness about PBM since 2010, and recently in 2025 they have published a PBM document to increase the implementation rate all over the world, centering in the population health status, protecting blood health, promoting blood health, and preventing diseases through PBM. And patient blood management in pregnancy starts before delivery, screening for iron deficiency quite often during pregnancy and treating accordingly during the second and third trimester. And PBM has, as all of us know, 3 pillars, but also 3 moments during the peripartum period: pregnancy, delivery, and postpartum. The standard of care in obstetrics in cases of p-PH needs to improve in 3 stages of labor in terms of PBM implementation, because we have to identify high-risk cases before delivery. We have to search actively looking for anemic patients, and we have to manage basic principles and bundles to minimize the blood loss. It is different, the situation, depending on the etiology or the appearance of coagulopathy and the evaluation of severity, and the resuscitation measures may make the difference, including the following of guidelines and point of care. Let's try to start with optimizing the red blood cell mass, that it's the first pillar of PBM. And that's iron deficiency. It is highly prevalent during pregnancy, and it has to be defined and actively tested during pregnancy, including iron metabolism. And anemia affects mother and child, having risks not only about transfusion, also neonatal risks, including intellectual disability, low birth weight, and many other risks associated to simply anemia during pregnancy. Anemia is a disease. It is not a number, and we have to focus not only on hemoglobin concentrations. We have to focus on anemia as a whole disease. The International Federation of Gynecologists and Obstetrics have published a statement about the iron supplementation orally, initially, and intravenous iron therapy reserved for women diagnosed in the second or third trimester or who cannot tolerate oral supplementation. We have to test, treat, repeat the test along the pregnancy and administer modern intravenous iron preparations when it is indicated. We have to measure. If we don't take a temperature, we cannot find a fever. It's the same with anemia. We know that we have to do different things. It is not a question of iron. We have to use tranexamic as soon as the bleeding episode, the PPH, is diagnosed. It has been demonstrated after the results of the woman trial in 2017. It is highlighted also in the Cochrane reviews that the use of tranexamic acid is useful to reduce the blood loss as soon as the PPH starts. And also during the delivery and the cesarean delivery, especially, the use of regional anesthesia techniques decrease the amount of bleeding compared to general anesthesia. Let's focus now on the pillar number 2 of PBM, that is the minimization of blood loss and optimization of coagulation. It requires a multidisciplinary approach, including uterotonics, tranexamic with early administration in less than 3 hours post-delivery, and the anesthesia technique, and also a PPH algorithm ideally guided by viscoelastic point of care tests. We have to come back to this image that illustrates that our job starts during pregnancy but continues during delivery and postpartum, including transfusion and coagulation algorithm guided by viscoelastic tests, cell savers, screening and treatment of iron after delivery, and close monitoring of blood loss during the whole period. That includes also a rational and restrictive use of allogenic products. It is important to know about the etiology and to be especially aware in the etiologies much more associated with coagulopathy that may increase the amount of bleeding. It means the T of tissue and the T of thrombin and the appearance and of acute obstetric coagulopathy that happens much more often in placental abruption and especially in amniotic fluid embolism. It is nice to be prepared in high-risk cases. We have to try to identify high-risk cases before a PPH, but up to 50% of cases happen in not high-risk patients. And we have then to evaluate how sick is our patient. And for that, we have the shock index, that it's nothing more than heart rate after systolic blood pressure, and to evaluate if it's over 1 or below 1. If we have shock index over 1, heart rate over 100, and estimated blood loss over 1 liter, the patient is at risk. And she is also at risk if she is tachycardic, pale, hypotensive, with pH below 2, lactate over 4, or even over 2 millimoles per liter, oliguric, and this patient deserves close and active monitoring. Briefly, a very few words about prohemostatic drugs that include fibrinogen, calcium, factor 13, PCC, and recombinant 7A factor, plus the traditional fresh frozen plasma and platelets. Ideally, they should be administered by algorithms guided by point of care and one by one if we need red blood cells units. We have algorithms that help us to guide the administration of some products, including fibrinogen, that could be considered empirically in case of massive transfusion protocols and etiologies closely associated to a high degree of coagulopathy like abruption or amniotic fluid embolism. If it's not the case, the indication is guided administration. Surgical treatment has changed as our sociodemographic situation around the world has been changing with the pandemic of cesarean deliveries. So in this setting, we have new treatments on the floor that include embolization and especially Riboa balloon. In the Riboa balloon, we have recently published a study with the anesthetic approach of Riboa cases. Also, we have the cell savers. The Salvo trial performed several years ago in the UK, including 26 hospitals, established that the use of cell savers is safe, can reduce the transfusion rate, it is not cost-effective as routine, and it may be a good option for Jehovah's Witnesses with acrotism because the risk-benefit helps these patients. Let's try to put some few things together with some emotive words. The E of early detection and trigger criteria in front of PPH. M of massage of uterus, O of oxytocic drugs, T of tranexamic, IV of IV fluids and resuscitation, and E of examination and escalation. These conclusions have been highlighted after a huge study performed in Africa with more than 200,000 women. The take-home messages from my point of view is that PBM and PPH need a multidisciplinary approach, that prevention is essential, especially applying the principles of PBM first pillar. We need clear definitions of a PPH and clear thresholds to start the treatment and quantification of bleeding. We have to start with basics, avoiding lethal triad, contact blood bank, and evaluate severity to have protocols, including local protocols that are especially useful if they include local phone numbers. Monitoring, not only technical, also human monitoring with scales, objective scales. And let's remember that transfusion may be harmful, but transfusion also may save lives. Thank you very much. I'm open to your comments or questions, and I hope to see you soon in Marrakesh from 15th to 19th of April next year. Thank you very much.
Thank you so much, Dr. Guasch, for this insightful overview of patient blood management in obstetric hemorrhage. And we'll save the questions for the end. And now we are going to jump into our second presentation from Dr. Seema Ranade, our trauma anesthesiologist, with the lecture PBM in Trauma, Saving Lives When Every Drop Counts. Thank you so much, Dr. Seema. Share your expertise with us.
Yeah. Am I audible?
Yes, yes, quite fine.
Can you see my slides?
Yes.
Thank you so much. So, hello everyone. I'm Dr. Seema Ranade. I bring greetings from India and from Ranade Accident Hospital, which is my main area of work. I'm a trauma anesthesiologist working in a low resource area for the past 32 years. So, I first of all thank Dr. Rosa and Dr. Freddy for allowing me to share my thoughts on patient blood management in trauma.
Dr. Seema, can you just open the slideshow, the icon at the bottom? Yes, thank you so much.
Yeah. Thank you. I have no conflicts of interest to disclose. A quick look on what is PBM. PBM is a patient-centered, systematic, evidence-based approach to improve patient outcome by managing the patient's own blood and also having a good outcome in the process. It is a multidisciplinary application of evidence-based medical and surgical concepts, which are aimed at screening, diagnosing, and treating anemia in the first place, blood recovery, blood conservation strategies, intra, peri-op, post-op, emphasizing goal-directed hemostatic resuscitation, quality governance, teamwork, and simulation. What are the learning objectives today? I'll throw a brief light on historical aspects and timeline. Then how do we apply PBM guidelines and incorporate them into local protocols here? A brief view of pathophysiology of trauma, the key challenges which we face, early interventions, tranexamic acid compression techniques, damage control, and a multidisciplinary trauma response activating local system. It was the year 1914 to 1916, the First World War, which saw the advent of blood transfusion, where blood used to be collected in milk glass bottles. Citrate was used as an anticoagulant. From one end of the war zone, the messenger used to literally run with the donor's blood, and the recipient used to receive it at the other end. This was how many lives were saved at that point of time. 30 to 40 years later, blood banks expanded with the advent of plastic. Blood banks used to be available now in plastic bags, and more components also started. RH typing started in 1940. We had a brief scare in 1980 to 1990s with the advent of HIV and HCV and the hepatitis B viruses. But this finally PBM term was coined by James S. Bister in 2005, and in 2010, the World Health Organization jumped the bandwagon. So over a period of time, in emergency medicine, PBM has evolved from transfuse to restore the volume to manage the patient's own blood and yet get a good outcome. We all know that maximum blood or massive transfusion protocols are required in major trauma, in obstetric hemorrhage, in GI bleeds, in ruptured aneurysms, in cardiac surgeries, in transplants, and so on and so forth. Now, why is this a burden? Why is trauma-related hemorrhage a burden, especially in low-resource areas? This is because trauma is responsible for 4.4 million deaths annually, and 50% of them occur within the first 24 hours due to massive hemorrhage. The young population is commonly affected. Ages 15 to 45 are most commonly affected. Delayed transport, lack of early birth products, worsen mortality. It causes a huge economic burden on the society. Nearly $1.7 trillion are used up globally annually.
Dr.
Trauma
Seema,
mortality is 3 to 4 times.
Dr.
Sorry?
Seema, just if you could speak just a little bit slower in order for us to translate.
Sorry.
Thank you so much.
Yeah, thank you. Trauma mortality is 3 to 4 times. Am I okay now?
Yes, amazing.
Okay.
Thank you so
Higher
much.
in the low middle income countries as compared to the high income countries. Delay in transfusion, lack of data, lack of research, and lack of all this documentation intervenes with the evidence-based protocols which are needed to build up a few guidelines. This is a shortened and simplified version in the table form of trauma-induced coagulopathy. Trauma causes a lot of hemorrhage, patient is in shock. Fibrinogen is the first product to be used up. This causes tissue inflammation. We all know that hypothermia, acidosis, hypocalcemia, hyperglycemia, all of them contribute, and trauma-induced coagulopathy sits in. The ATLS has classified shock into class 1 to class 4. Class 1 less than 15%, class 2 15 to 30, class 3 30 to 40, and class 4 more than 40%. In class 3 and class 4, you need blood and activate massive transfusion protocols. This is a sort of guided line. So right from the point the patient has an accident to the definitive treatment which is carried out, and they have nicely tabulated it. So from R1, which is the minimum time which is necessary actually, so as to get a maximum patient outcome, stop local bleeding at that point of time, assess a good airway, get the patient to the hospital, initial assessment as per the ATLS guidelines of A, B, C, D, E, immediate intervention if necessary. If there is massive bleeding, go for damage control without wasting much time. At the same time, send the blood for labs, send the blood for grouping, cross matching, see what is available. If you have whole blood, it is the best at that point of time. Also alert all the teams which are necessary: the OR nurse, the orthopedic surgeon, the intensivist, the anesthetist, the blood bank, the radiology department, and the hospital admin, so that they can also do their bit here. Volume replacement, targeting blood pressure, using vasopressors early, using crystalloids in minimum. Do not over resuscitate, goes a long way in managing the patient. You also give normothermia. Do not make the patient hypothermic. This adds to the woes, and patient quickly ends up in the deathly pentad. Now, this was what I was coming to. Initially, it was a deathly triad. Now it has become the deathly pentad. What is a pentad? So hypoxia and ischemia causes hypocalcemia, acidosis, hyperglycemia, hypothermia, and finally coagulopathy. Why this is important? Because all these parameters, if you limit them, then we do not proceed to coagulopathy or DIC. You can use balanced crystalloids, early use of blood products, prevent hypothermia, prevent acidosis, and go for early damage control. And this is how you prevent the deathly pentad. Now, the thromboelastography and TEG and ROTEM are very good bedside tests. However, lack of availability in many centers and especially in low resource areas limits their use. But to this moment, they are really good indicators of point management. Like they tell you if the patient is needing fibrinogen, or patient is needing blood coagulation factors, or patient is needing whole blood. So this is how a normal thromboelastograph looks like, and it has a few parameters like the R time, which is a time to initial clot formation, which is actually 6 minutes. More time denotes a clotting factor deficiency, and here you need to give fresh frozen plasma. The K time is a time from the initial clot formation till it reaches an amplitude of 20 millimeters. If there is fibrinogen deficiency, you have to give cryoprecipitate or fibrinogen, whatever is available. Low or dysfunctional platelets, the graph looks something like this. You have to give fresh platelets. In a thrombotic patient, this is like a cylindrical thromboelastograph. Here you have to give anticoagulants right away. Primary fibrinolysis, the graph looks like this. Antifibrinolytics or tranexamic acid is the drug of choice here. And secondary fibrinolysis is treating DIC. This is the thromboelastograph. Now, the key challenges which we face in acute trauma management is there is a delayed recognition and control of hemorrhage, lack of focus, USG, TEG and ROTEM, limited access to blood components, especially clotting factors and fibrinogen, inability to implement damage control resuscitation, limited pharmacological adjuvants, shortage of trained staff, inadequate surgical and interventional capacity, ethical and logistical constraints in blood allocation, lack of O negative blood many times, data gaps for documentation and no auditing. This is how the cell saver autologous red blood transfusion is done. The patient is bleeding, there's abdominal bleed, the citrate is added in the blood. Blood is collected in the reservoir. It is now washed with saline, centrifuged, waste products are collected, and packed cells are given. This can be still done and is still done in some centers. Multidisciplinary trauma response is now done in many areas, and even in our low resource areas. Early activation, single point alert. One phone call activates a number of people. We use ATMIST or MIST structured communication format to hand over. We have a few algorithms. We have number 108 ambulance services in India all over. We provide paramedics with lot of training and yearly mock drills and simulation drills. There's a good rural to tertiary care center transfer communication drill. Here again, going back in short, pre-op, treat anemia, intra-op, surgical hemostasis, tourniquets, compressions, packing, use of balloon tamponade, use of uterotonics, use of cautery, hypotensive anesthesia, post-op, again repeat hemoglobin and a few parameters, document the indication for blood transfusion in the first place, treat ongoing anemia and give good antibiotic cover. The trauma team activation in a minute, call received, activation triggered, team is mobilized in 2 to 4 minutes, resus bay is prepared, airway, USG, arrival of the patient, primary survey, fast intervene, rapid decision making, take the patient in the OT, take the patient in the ICU after definitive treatment, step down, document, handover, and do a debriefing of the entire team in the next 10 minutes. In the low resource area, this is what we do. We have a following tests only: CBC, liver function, serum creat, PTINR, D-dimer, and APTT. A rise in APTT more than 60 seconds suggests an ongoing bleed. This, along with a deranged liver function and renal function, and a rise in D-dimer, suggests an indicator for DIC. PBM in India. Why is PBM needed in India? Again, I come back to the same things. The blood supply challenges, transfusion practice challenges. So we have adopted a few PBM pillars in India too. Aggressive screening and treatment of iron deficiency anemia in menstruating girls, in pregnant women. Use of oral IM, IV iron before elective surgeries. And a lot of public education is done. Pillar 2, early use of tranexamic acid, standard massive transfusion protocols, encourage cell saver use, encourage surgical hemostasis, use viscoelastic tests where possible. Pillar 3, optimize, build the patient's tolerance to anemia, use any other methods and increase transfusion thresholds. My share of massive emergencies in my small town was, there was a big train accident in 2004, 20 fatalities and 100 casualties. Bridge collapse in rains. We are a declared flood area. 42 people died and there were many casualties. 2020, a big building collapse, killing 12 people and injuring 60. These are the grim pictures. I feel so bad when I need to share them with you. This is how the train accident was. We have a few, I went through a few things around the world, a few literatures, and I found out that they are also on the same page as us. We are much more better now as a low middle income country. Audit which we carried out at our hospital, we do nearly 16 blocks. We do nearly 60 to 70 surgeries per month and around 20 to 25 blood transfusions. We try to save as much blood as possible. Quality improvement cycle is done regularly in our areas and in low resource areas. The PDSA, everybody knows, plan, do, study and act, so as to continue monitoring, update local protocols and root cause analysis. Emergency PBM checklist, again, activate massive transfusion protocol, use tranexamic acid. This is the the International Blood Transfusion Society and the WHO guidelines, as well as the AABA guidelines. Give tranexamic acid 1 gram IV in the first 3 hours over 10 minutes and the next 1 gram over 8 hours. Warm the patient, give warm IV fluids, goal directed PBM, look for transfusion triggers, monitor labs every 30 to 60 minutes, correct calcium, correct fibrinogen, maintain the pH, maintain the temperature, deactivate the protocol when the patient is stable. Take home bullets, try to minimize blood loss, prioritize the source control, preserve patient's own blood as far as possible, promote autotransfusion and cell saving, target the systolic blood pressure to 80 to 90 milliliters of Hg, avoid resuscitation, minimize crystalloids, early use of whole blood definitely is good, activate a clear massive transfusion protocol, PRBCs to FFPs to platelets, give tranexamic acid early, if possible, use viscoelastic tests like TEG and ROTEM, prevent and correct the lethal pentad before it goes to coagulopathy, prevent it. Trauma patient blood management requires protocols, team training, simulation and audits. So early detection, rapid triage, sound decision regarding PBM and an all-round teamwork is all that is needed to save life even in a low resource setting. These are the references which I went into. Coming together is a beginning, keeping together is progress, but working together is success. That is what I have learned in the past 32 years. Thank you so much, guys, for listening to me. Thank you.
Thank you, Dr. Ranade, for this powerful talk. Thank you so much. Now we are going to our third speaker, Dr. Angel Augusto Pérez Calatayud, with his session, Integrating PBM into Emergency Protocols, Tools for Action and Audit. Dr. Angel, the stage is yours.
Thank you very much, Diana, and thank you for the WFSA for the kind invitation, and to all people present to hear a little bit of what we can do with PBM implementation. And obviously, I want to be really emphasized in the document that was released by the World Health Organization, because almost everything you need is right there. And one of the things I just want to ask Diana, you can see my slides and they're changing, correct?
Yes, yes, everything works fine.
Thank you. So this is my conflict of interest. I'm right now working in implementation projects in Ibero-America, and working with a lot of hospitals and societies to get the implementation of patient blood management right into place. And one of the things that we need to understand is we know the evidence out there, and sometimes when we're talking in countries where blood is scarce and we have budget limitations, it's a lot more difficult to try to do this. And as you have heard in the other talks, it's not necessarily impossible. We just need to get together and integrate all the knowledge we have and all the resources we have into trying to make it happen. One of the things, and I like to show, so you can meet this amazing guy that is Guilherme Ravelo from Brazil, that he has this amazing presentation when he talks about PBM like it was a Lego, that you get all the pieces, but you don't know how to assemble until you get a manual, and then obviously you can do beautiful things. And this is what the guidance of implementing patient blood management to improve global health status can help us out. Obviously, I mean, if you don't have access to some sort of IV iron, then you probably will need more time to do the treatments. And there is always some difficulties when you want to do an implementation program or an implementation process. But I think, and I'm pretty sure, and this is something that the documents always say, union is power. So there's different ways of implementing patient blood management. They are all in, available in the internet. So you have Carter's, Lewin, ADCAR, change management models. But if either one that you use, and this is how they create the whole concept of implementation, is establish the feeling of urgency, formulate guiding coalition, develop strategy, empower employees, capitalize, communicate for the vision of the strategy change, generate short-term goals, and incorporate this into new changes in your workplace. So obviously, when we try to land this into the patient blood management concept, you're going to hear the 3 E's, that it's evidence, economics, and ethics, and the 8 that is now the model of implementation, when you can start obviously low in your work areas, and then just scale it into a national program so you can get help to include more technology or more medication into this. And obviously, when you see the jurisdictional phase and you see the roll it out to national scale, the first part is to start a pilot. And as all we know, obstetrics, it's a really good place to start, because we know we have problems, and we know there is a lot of mortality still there, especially in low income and middle income countries. And when you go to the part of how can I change practice, the first things you need to know is to establish this sense of urgency and create coordinator groups, preparation in hospital levels, and obviously in first level or first contact healthcare providers to integrate into the patient blood management model, so you can start do something. So obviously, I mean, you have 9 months to treat anemia, so you have to establish an anemia treatment, and then you can create the working group when you can get data collection. So, I mean, we know, and they already talk about the multiple trial. These things are doable, and if you get numbers and if you get results, then you can scale it out and try to get some help into this. So if you review the document of the World Health Organization, there is a whole toolbox of how you can integrate anemia treatment, taking into account, obviously, the problems that low-income country has. Then you have what you can do into blood loss and bleeding. And I mean, here, obviously, the first part is you need to close the key, we call it the drain. So we have to stop the bleeding. And then treatment of coagulopathy probably could be avoided. So the need for other medications or more transfusion could be avoided if we correctly stop the bleeding. And there is some local things that you can do. And there is some, obviously, more technological stuff that probably you will know. So one of the things that understand the integration of patient blood management is that this has to be a multidisciplinary, multi-professional approach. So you need to get everyone involved on why it's important and how to do it together. So you can have what's your problem, then create the algorithms with what you have, start the prehabilitation, and remember that there is not an order to treat anemia. Anemia can be treated pre or post. Probably you have been doing this for a lot of time. Then perioperative coordination and individualized management. Always get the data on hand, because this is how you can do a proof of concept when you want to scale it out into administrators or into a national health stakeholders. And this obviously will have an impact in improved results in your health. So also, if you have medical societies, get together with them to start doing all the knowledge into anemia management, bleeding management, and post-op management, So everyone gets together. I mean, trauma societies, OBGYN societies, anesthesiology societies can help get together the information and how to put it into place with your own realities. And this comes from an approach also. I mean, you have the Qatar cultural change management, but then you have the Abetis Donavidian, that it's something about quality into healthcare. Then when you integrate it, you know that you can have the quality of a structure is to get what you have, then create a process where you get all the algorithms together and see what your indicators and your goals are going to be, so you can achieve the quality of outcome. So in this, when you go through each one of them, obviously you need to go in order to ensure the quality of the structure, then ensure the quality of the process, and finally have the quality of the results. And the quality of results can help you change some part of the process when you get the data on. And obviously, when you see the process, then you see where you have holes or where you have a space for improvement, so you can change the quality of a structure. And this obviously can go from either way. I mean, it doesn't have to be an order, but it will help you out to improve this. And you already see the results of the emotive. When the results are just amazing, it's without a lot of things, just getting in together a process of treatment and a process of attention, you get a really nice reduction on mortality. And you see also that there is a lot of detection and adherence to the treatment. And this also happens when everyone works together. And as you know, this was not done by doctors, so it was done by health workers in the region of Africa. And the results of the reduce of mortality was just over the top and amazing, and even get in numbers of high-income countries when they start the treatment. And we know patient blood management has also been able to prove in obstetric and in trauma settings a lot of improvement without necessarily going into the transfusion part. So obviously, again, probably you need to get together with the surgeon, with the anesthesiologist, and see, okay, what we can do, and getting together and deciding how to do the approach. So as a recommendation, and there's a lot of guidelines you can download when you can get all the evidence and then try to put it into local evidence and into local strategies and into local protocols and guidance to help you out to improve outcomes. So here's an example. For example, if you do the preoperative and then you have the anemia clinic, vascular control, when you have access, it can be either goal-directed therapy, either through viscoelastic systems. If you don't have it, then go to a standard coagulation test. If you don't have it, then just to put the small sample of blood into a glass tube and see how long it takes to coagulate, and you can make some decisions if there is a need to treat coagulopathy into these patients. And there is a really importance when we talk about the continuum of care. It's to create the group is if you're going through obstetric hemorrhage, then you have to integrate the emergency part of this, then you have to integrate the health workers of this, integrate the OBGYNs, general practitioners, anesthesiologists, intensive care physicians, and all work together to get the goal ongoing. And this is how you get better results. And as you can see, then we have a continuum in the post-operative period of what everything that was done. And then obviously there is also an important part of treating anemia. If we have anemia after the bleeding happened, then we really have to start to treat the anemia. And we know that we are not going to have results right away, but we are going to have results. And this is some example of algorithms that we do with anemia treatment, obviously lab-based or with the medication we have. We need to understand what the prevalence and the causes of anemia in our region are. And this is an example of obviously viscoelastic testing. You already saw this in the trauma presentation that was amazing. But as you can see here, for example, in postpartum hemorrhage, we have when we have viscoelastic testing, then we can do it with that way. But if not, then we have a standard coagulation test, and we know that they can be done in less than 15 minutes, and you also get results and still doing a goal-directed therapy into the patients to improve the outcome. And this will help you to have an organizational preparation. So you need to discuss with the stakeholders. Always education and training is important, and it's one of the other pillars of p-PBM to start the clinical implementation and have a quality improvement, and the hardest parts to become sustainable. This means that even if you're missing in the hospitals or in the area, these continue to happen because you establish a process of attention, you establish an algorithm treatment, and you have a goal and indicators to achieve this and see what is happening with your results. So there is a lot of documents right out. These are some examples of the ones that we already have in Mexico. And right now we have national guidelines. We have a certification process for hospitals. We have an alignment, and we're doing all this work with the societies and multi-professional to try to get the structural adjustments that we know we need to start to take care of processes and then have a nationwide impact and help to get the Ministry of Health of the people related to health to help us out with all this, selecting our pilots, and the pilots have to be chosen wisely, and always try to do this whole process through a continuum of care. That means from day one, that when you get the patient to the discharge of the patients, all get together to know what you can do and how to establish the protocol to get better outcomes. So this guidance is going to help you out a lot with the 8 model, and obviously you have to adapt to the context and to try to get systemic and cultural transformation, and this will help you to build an institutional and national capacity. So thank you very much for hearing me out.
Thank you, Angel Augusto, for this outstanding presentation. Congratulations for the amazing work you're doing in Mexico. This is a great example how to start and where we can go after p-PBM implementation. So now I believe that we can all jump into this webinar, and I invite all the speakers to be present, and we will start with the Q&A. Please feel free to add any questions you have in the Q&A section in the Zoom. And to start this discussion, I will start with a pre-submitted question, and if to any of our speakers who is willing to answer. And I would like to hear some comments about component therapy versus whole blood. I know that this is now a new era. Whole blood is jumping in. And what is your opinion about it?
Hello? Can you hear me?
Yes.
So can I answer this?
Yes, Dr. Seema, feel free.
Yeah. Thank you. So, whole blood as compared to components, whole blood has got more brownie points, I should say, than components. Whole blood is easily available. It is cost saving, and you can give smaller volume, especially when you don't want to over infuse the patient. One volume or one bag of whole blood is equivalent to, say, 3 bags of PRBCs and platelets and FFPs. Whole blood is also used in low resource, easily available, like I told you, in low resource areas. And in whole blood, we have the clotting factors and fibrinogen and the platelets fresh without their efficiency going down. Whereas if you go for components like the platelets or the fresh frozen plasma, for platelets, if they are more than 14 days old or whatever, their potency or the efficacy has gone down, they are near not useful. Whereas in fresh frozen plasma, you have to thaw it, so it takes some time. So there are so many challenges or so many things which are against the use of blood components. Whole blood at this moment of time is according also to WHO and the ISBT and the AABA is recommended in trauma, especially when you don't want to over infuse the patient with crystalloids, when you have a cardiac patient, when you have a pregnant mother, when you know that you need to do damage control early. I would definitely recommend whole blood. If you have a patient of hemorrhagic as well as cardiogenic shock, you can still give whole blood in aliquots of 150 or 200 ml. Again, monitor the vitals, monitor the labs, and go on, and so on and so forth. Components are only or more useful, say, in some special situations, like you have a patient with liver dysfunction, you have a patient with factor some 13 deficiency, or you have a patient of thrombocytopenia. Then these components are the thing which we need to do. Otherwise, whole blood still stands the test of time.
And what you are referring to low resource settings? Yes, Dr. Seema?
Yes.
I have
Even in a setting where everything is available, whole blood is still recommended because of the very fact that one whole blood is enough to start resuscitation process,
Yeah.
rather than packed cells with platelets with FFPs thrown in. So 1:3, if you compare, one is definitely better. According to the rule of 1 liter of crystalloids,
See.
give one chance and then go for one whole blood.
I have to say that I have never seen whole blood because our blood banks use fractions for everything. And they don't have availability of whole blood at any blood bank, at least in Spain, and I guess that in Europe.
Yeah, I believe that we are talking about low resource settings because we are going to precision medicine to give only what the patient needs, do viscoelastic tests. We are working in this personalized medicine approach. We have to realize that there are some areas around the world that don't have access to viscoelastic tests or factor concentrates. And I believe we have here different realities.
Yes,
Yes.
it is important to know that whole blood is not available in some areas also.
Yeah.
Yes.
Your opinion,
We
Angel.
have packed cells also. We have packed cells and we have fresh frozen plasma. As far as platelets and cryo and everything is concerned, that is still not available. So much as compared to these things.
Your opinion, Angel.
Sorry?
I'm asking Angel to add his opinion.
Well, obviously I'm a evidence-based type of practitioner, so for me right now it's a no, no. And obviously we need to understand PBM as this approach where everything that we can do is to avoid the transfusion at the end of it, but it's more about getting better results. And I mean, the reduction on transfusion is going to be just there, obviously. And the use of whole blood, it's it's something that it's happening right now everywhere around the world, that it's getting a lot of attention, but the evidence is still too scarce to do it, I think. So yeah, if we have another approach, I definitely would go to the other approach by far. Yeah.
Yes, I believe we
In my
have
setup, so can I just
yes,
add
yes,
one
yes.
thing? In our setup, when we have a patient of polytrauma who has come with a massive bleed, and like I told you, we have whole blood, but we also have packed cells and we have FFPs. So we go in the ratio of 2:1. 2 packed cells is to 1 FFP, fresh frozen plasma. Whole blood, although we do have, but we also have PRBCs and FFPs. So 2:1 we do give, but if that is not available, or if the patient has a rare blood group, then whole blood comes in vogue. Like if he has a O negative or B negative group. Yeah.
And do you have access, Dr. Seema, in your institution to viscoelastic tests?
We don't have.
No.
No.
And you have a lab test result quite easy to achieve. It's easy to have standard lab tests available.
Yeah, yes, lab tests are easily available, but we have a few limitations. Like we don't have serum fibrinogen or the factor deficiency tests here where I work. We go as far as APTT,
NTP,
PTINR,
yeah.
D-dimer, yeah, and the routine hemoglobin hematocrit and all. But that is all. So we go by clinical more. And if we have, like I told you, I mentioned in the slide, if we have a deranged liver renal function, and if we have a raised D-dimer and an APTT more than 60 seconds, then we assume the patient is going in DIC.
Thank you. Now, I will move to another question. We'll move to PPH. And I have two questions here that are quite repeated. That one is about iron deficiency during pregnancy, when to treat with oral iron or IV iron. And the other one was about when to give tranexamic acid in a PPH scenario.
Well, starting for prevention of anemia, the first thing that we have to be aware of is about detection of anemia. We have to test. If we don't test, if we don't measure, we will not diagnose anemia. And we have to test our patients in the first trimester, in the second trimester, and in the third trimester. And we have to convince our obstetricians to do so and to supplement with oral iron. And if it's not well tolerated, if the anemia is very severe, we have to move to IV iron solutions. There is one question here that I was trying to answer online, but I will answer at this moment, that it's about the safety for fetuses and some advices from governments in Europe about the fetus safety during iron administration. I think that IV iron has been demonstrated safe enough for our women and for our fetuses, but the administration is advised at the hospital. I think that if the pregnant lady is at the hospital, it is safe enough for the fetus. And regarding the tranexamic acid moment to start the infusion is once the p-PH has been declared. We need good definitions of p-PH. p-PH is classically defined as a blood loss of more than half a liter or more than 1 liter after a vaginal delivery or a cesarean delivery. If you have defined it and declared the p-PH, that's the moment to start the tranexamic infusion. 1 gram in 10-15 minutes, not a fast infusion. And at the moment, it is not indicated the prophylactic administration of tranexamic acid.
Thank you so much. Very clear and very straightforward answer. Thank you so much. Dr. Seema, do you have tranexamic acid in your institution?
Yes, of course.
Yes. Yes. So
Yes.
it's something that is quite available worldwide. It has
Very easily available.
specific contraindications also?
Sorry?
Contraindications for tranexamic acid.
Contraindications I haven't really come across. Among all the trauma patients which we give, only one had an anaphylactic reaction. Generally, when we give a loading dose of 1 gram in the first 10 minutes, we are supposed to give IV slowly diluted. That is how I give it, because of the fear that any patient might have anaphylaxis and it will worsen the already bad patient. But this has occurred once or twice, that's all.
Yeah. I was
Otherwise,
asking
there are no real.
I was only asking you because of the snake bite. The snake bite. Everyone asks always about tranexamic acid. Yeah.
I had my share of snake bites here too, because we have crate bites here, and crates are neurotoxic. So I am often called to secure the airway.
Yes.
But we have saved so many people.
And keep going on p-PH. We talked about anemia prevention and treatment. We talked about tranexamic acid, when to give it, and once the bleeding is happening, there are still a lot of evidence, but also a lot of questions about the use of cell salvage in obstetric scenario. What message can we pass to our attendees?
Well, thank you for the question, because cell savers always come out like an iterative question. There is a huge study that I mentioned during the talk, that it's the Salvo trial that was performed in the UK almost 10 years ago. It included 26 hospitals and thousands of parturients, and they established it was a safe procedure, but it was not cost effective for the general population. So it could be a good option when we have a very well-known and diagnosed placenta creta spectrum patient, or a placenta previa, or any other very high-risk case. We can manage to deal with the case with a cell saver safely from the amniotic fluid embolism risk, because it has not been described during the use in that huge study, the Salvo trial, I repeat, but it needs skilled people to manage the cell saver properly. The only one problem that has been repeatedly described is the isoimmunization with anti-D. So you have to repeat the vaccination or the prophylaxis of anti-D. That's the main risk. And I would not advise the general use of cell savers routinely, only in high-risk cases. Jehovah's Witness, placenta creta spectrum, Jehovah's Witness with placenta creta, because for general Jehovah's Witness, it's not an option.
And just to add a simple question, in cardiac surgery, we have the opportunity to use cell salvage in 2 different settings. you can use it only as a regular aspirator, and then to process the blood and the rest of the equipment. So it cannot be as expensive if it's not, if the blood loss is not meaningful, you just don't use it. It was just like a regular aspirator. But in order to just be prepared if you have a bleeding scenario, that can be an option, I think. But I don't know if every cell salvage has these options of being just prepared both ways, as aspirator or as a cell salvage.
We need, in PPH scenario, we need 2 aspirations, because at the beginning we have a lot of amniotic fluid.
Yeah,
and
that goes.
should not be reinfused. And the
Yes.
cell saver that we may use is that one that is able to reuse the washed and filtered blood. Only washed and filtered blood.
Yes.
For
Yeah.
reasons.
Mm.
You are going to speak, Angel.
Yeah. I mean, we have the presentation, and there is even some commercial brands that are already doing this type of work, when you can separate the blood, and only when it goes into some amount, then
You
you start
reinfuse it, yeah.
the cell salvage and refuse it. And I mean, obviously in PPH, there's always this fear of the amniotic fluid, but I mean, at least what they have published, and we have used it, the problem is not there if the machine works well, and it normally separates everything, so we don't have that complication. So yeah, I mean, for me, it's a no-brainer that the cell salvage, if you have access to this technology, obviously, having like have it there ready, not use it, but have it ready, and obviously we'll always reduce cost, and will help you out to reduce allogeneic transfusions for sure. Now, in liver transplants, for example, then I mean, we use it all the time, because
All
we
the
know
time.
they're all the time. So we know they're going to bleed, obviously, and we know we expect at least 3,000 milliliters or no, on 2,000. So we know we can open it right away. But we had that problem, same as you in cardiac surgery. So they opened the
kit.
equipment, the kits,
Yeah.
and then the patient bleed 400 milliliters. So obviously, it was expensive and it was not used. So that's the reason we decided to change to the other technology, and it works quite nicely. Yeah.
Yeah, that's an option. You can use it only as an aspirator, or just put the rest of the equipment and use it as a cell salvage. And
Yeah, the cell salvage
as a-
we have
yeah.
doesn't have that option, but there is like it's the canister where you
Yes.
aspirate the blood that has a connection into
Yes.
I mean, it's an
Okay.
external one, but has the connection to get the blood to the cell salvage. And I mean, the big difference is that obviously you treat with heparin the blood that is coming into the canister in case you have to use it.
Yes.
And then it goes right to the cell salvage technology. So yeah, I mean, there's
Great
options.
option.
Yeah, it's a great option. Agree.
Great option.
Mm-hmm.
Just one not a question, a comment regarding using of cell salvage. Sometimes I see people saying, okay, we are using cell salvage, but our patients sometimes bleed. And I believe there is one question, or there is one thing that people that are using cell salvage has to remember. When you are losing blood and you are reinfusing RBCs, there are the other components that are going to be wasted. So you have an amount of blood where you should think about collect a blood sample, if you have access to viscoelastic tests, run your Rotem or other equipment that you have, and see if your patient needs something else. Using cell salvage is outstanding. We are saving a lot of RBC transfusions, but you should be aware that if after a specific amount of blood for your patient, maybe your patient will need some specific factor concentrates in order to keep the coagulation efficient.
Can I add a case?
Do you want? Yes, please.
We have a patient of Bombay blood group in our district. In the surrounding district, there's only one patient. He's obviously registered in the national registry as well as in the state registry and all that. During COVID time, there was a patient posted for cesarean section at our in my hometown. She was Bombay blood group. Now this guy we contacted. He came on riding on his bike, motorbike, all the way some 200 kilometers, because that time transports were not there because of COVID. Everything was at a shutdown. But he came, we respected that the cesarean section went on uneventfully. He didn't have to give his own blood, but that is how the patient was saved, or the patient had an uneventful delivery, because this guy rises to the occasion, and we have only one of that sort in the entire sort of area here in our state and whatever. So this is a thing which we have done, and we have access. He's registered in all the registries as well as the national registry, so we don't fall short in times of need.
Thank
where
you so
rare
much.
blood groups are concerned. Yeah.
Thank you so much, Dr. Seema, for for sharing with us. Now I have one question for Angel. And
Hi.
Angel, do we need to have everything to start running a PBM program?
No, obviously not. One of the things and I think this is also something that happens worldwide, is that when we think that we want to start a PBM program, we automatically say we need to have the cell salver, we need to have viscoelastic testing, we need all the factor concentrates, and that's actually not true. Once again, what we need to do is just to establish, okay, what we have, and start with something. So it can be anemia treatment, it can be goal-directed therapy, but always start to try to do this in a group way, in a multidisciplinary way, and with whatever you have. I mean, if you have access to only whole blood, as it has been part of the discussion, because the chat is just full with whole blood, and you only have this, well, use it, of course. I mean, that's the only thing you have. This will help you out in some way. And when we started this, for example, in some hospitals, I mean, I have hospitals that didn't have cell salvage technology, didn't have viscoelastic testing. So what they introduce is a goal-directed therapy through a standard coagulation tests. There's also a big example of this in Argentina, in a big trauma center, when they say, okay, I don't have access to viscoelastic testing, but they talk with the laboratory, and when they activate a trauma code, they say, please get me the results in 15 minutes. And the laboratory did that. So they kind of did some goal-directed therapy through a standard laboration test. And they also have this impact in reduction of coagulopathy, reduction of blood loss, obviously indirect reduction on transfusion. And they also are sharing that the mortality rate went off also. So, I mean, this is a big example that you don't need to have everything. In our country, this also happened. And one of the things that happened when you start to do the whole protocols, and then you start to get some results, and the results are good, then obviously people start asking for things. And then there's a lot more probability that administrators will turn around and say, okay, yes, we need them. And there is also something that we say to everyone here in Mexico, because when, for example, we have budget restrictions for sure, and we have areas that we have really low income. So middle income countries behave as really different between the states. But one of the things I always told them is, I mean, if the head of anesthesia comes to the administrator and says, I want ROTEM or I want viscoelastic testing, they always say no.
Yeah.
But if the head of anesthesia, the head of surgery, the head of OBGYN, the head of critical care, and the head of emergency medicine, the head of the blood bank, and everyone says, we need this, then they will probably say yes. I mean, they will try to get somehow the budget into place. And this happens a lot. And again, I mean, I can tell you right now that probably of the 35 centers that we have right now in Mexico fully implementing patient blood management, 80% of them do not have everything. And they're still doing a really, really good work. And most of them in a 6-month period are already reporting reduction on transfusion, reduction on hospital length of stay, reduction on infections, reduction on thrombosis. So yeah, I mean, get your KPIs, your indicators into the whole process. Always the data collection is important. The group work is important, and you can do amazing things without having everything.
And for me, the eye opener was the Niger work about PPH. They are the last time I checked, the maternal mortality was more or less like the United States. So we are talking about different realities, and what they did was to optimize what they have.
Exactly. And that's true. And this also happened with the coloproctologists. We have this surgeon that was a little bit, I mean, he was the head of the department and it was a little bit redundant about PBM. But then he started to apply, and now he only does 2 things: pre-op anemia treatment, and then be really meticulous into vascular control in the surgery. And he has already around 200 something surgeries without a single blood of transfusion need. And we're talking about big surgeries. And I haven't seen a patient of him in the ICU for a long time. So I think something is really nice. I mean, something's working really nice there.
Yeah. I really believe in this, and I would like that this could be a good message that you can take away from this webinar, is that you don't have to have everything, but you have to know how to appropriately and adequately use everything that you have. Update your tranexamic protocols, update the early detection of bleeding. I believe that is one of the most important. Late is always, cannot be too late. Early detection is the key for PPH or any bleeding scenario. You just have to optimize what you have. And then, as Angel shared with you, having your data will give you the power to improve what you have, to identify specialities or healthcare working groups that you need to update. And you can do PBM everywhere, anytime, with every patient, not only severe patients, but also medical patients, elective surgery, urgent and emergent scenarios. This can be a powerful message. Just update what you have and look at your data. Now, I believe that we are almost at the end of this discussion. I would like to ask our 3 distinguished speakers, before I thanking them so much, to leave a final message for our attendees. Dr. Emilia, you were the first. Go. Give us a takeaway home message, please.
Well, we need the leadership. We need to convince other stakeholders, and we need to be present in the delivery suites. Our presence, our leadership, and our force to do things right will help our parturients and our women to be much better and safer in terms of PBM.
Dr. Seema.
Managing traumatic hemorrhage especially in a low middle income country is not impossible, good teamwork, sound knowledge of what you're going to do, and making use of the best available resources at that point of time, and not giving up. Always, there's some answer to whatever you have come across, or if there's a wall, you can always have a window open somewhere. So don't give up and go on updating yourself, go on forming a good team. And that is how we encounter or we face our trauma patients day in and day out for the last so many years.
Thank you so much. Angel.
Well, for me, it's only that for them to remember that together we are a legion. So it's important to get everyone involved. And if you work in groups and you work together, the amazing things will happen. And always remember 3 E's, the 8 of implementation, and the 3 P's, evidence, economics, and ethics. The 8 of implementation from pilots to national implementation, and finally, the 3's of public health, promotion, prevention, and protection. And then you will have a really good PBM program despite the limitations and the budget limitations that you are living into.
Thank you so much. Now for our attendees, don't forget to complete the post-webinar evaluation to receive your certificate. If you are a member or if you are connected to your anesthesia society, please push them and bring them to join the Santa Cruz Global Declaration in order to improve perioperative patient blood management. And now, as we are concluding this webinar, I'd like to sincerely thank our distinguished speakers, Dr. Emilia, Dr. Seema, and Dr. Angel Augusto for their excellent presentations. I would also like to thank the WFSA for making this webinar possible, and also our sponsor, Global Health Workforce Program, to make this webinar possible. And just to conclude, I hope you'll join us in the WFSA Congress, the World Congress of Anesthesia, in Morocco from 15 to 19 in April. I hope to see you there in order to share, learn, and promote this area that we love so much, patient blood management. Thank you all.
Thank you, Dr. Diana, for conducting this seminar so well and making us so comfortable throughout the entire webinar. So thank you so much.
Thank you.
Thank you, Dr. Augusto. Thank you, Dr. Emilia, ma'am. Thank you so much. And it has been so nice meeting you. I hope I can come to Morocco so we can meet in person.
Thank you so much.
Thank you.
Thank you so much.
To all of you.
Yes.
Bye-bye.
Pleasure meeting you guys.
Bye.
Bye. Bye.